Good morning to all. Today's topic is on risk assessment and genetic susceptibility to periodontal diseases. Risk assessment in periodontal disease learning outcomes are categorize all risk assessments, list three risk factors, explain in detail about risk assessments, use risk assessments during treatment planning. Introduction. The aim of risk assessment is to evaluate the prognosis reliability. Prognosis is an essential part of the periodontal care and it influences treatment planning considerably. From a clinical point of view, the stability of periodontal conditions reflect a dynamic equilibrium between bacterial challenge and an effective host response. So, coming to the risk, what is risk? So, as we said before, risk determines the prognosis of the case. So, in periodontitis, it's very important. So, risk should be assessed before treatment planning. So, it could influence the treatment plan, also the outcome of the treatment, and also the response to the therapy. So, risk is defined as the probability then that an individual will get a disease in a specific period of time. So there are different risk elements. So we are moving on to the various risk elements: risk factor, risk determinant, risk indicator, and risk predictor. So this is a risk that we said before. That is the probability that an individual will get a specific disease in a given. So what are the risk elements? So coming to the details of each risk assessment, first comes risk factors. It could be environmental, behavioral or biological factors that when present increase the likelihood that an individual will get the disease. So it could be either of these factors. So this is when present which increases the chance to get the disease. Okay. So that is risk factor. So risk determinant or background is the same as that of risk factor, but that cannot be modified. So that is this characteristic which sometimes substituted for the term risk factor should be reserved for those risk factors that cannot be modified. Then comes risk indicators. So risk indicators, they are probable or putative risk factors that can have been identified in cross-sectional studies but not confirmed through longitudinal studies. So when you talk about what is the difference between cross-sectional study and longitudinal study, cross-sectional study, that is you can collect the data from the population at a specific point in time, whereas in longitudinal studies you are collecting the data from the exposure to the outcome of the disease, that is repeatedly collect data from the same sample over an extended period of time. Okay, so then comes the risk predictors and markers. Although associated with increased risk for disease which do not cause a disease, so these factors are also identified in cross-sectional and longitudinal studies. For example, lack of bleeding on probing, this appear to serve as an excellent indicator of periodontal health, but the presence of periodontal bleeding on probing alone is not a good predictor of future attachment loss. Okay. So coming to some of the examples under each risk element, under risk factors, tobacco smoking, diabetes, pathogenic bacteria, microbial tooth deposits. Then comes risk determinants or background characteristics. This could be genetic factors, age, gender, socioeconomic status, stress. Then under risk indicators, we have AIDS, osteoporosis, infrequent dental visits. Under risk markers or predictors, previous history of periodontal disease or bleeding on probing. So we are moving on to the details of each. So risk factor, as you know, the first one is the tobacco smoking. That is a clear risk factor for periodontitis. So there is a direct relationship exists between the smoking and the prevalence of periodontal disease. So this association is independent of other factors such as oral hygiene or age. So it could affect the periodontium in either increases the likelihood or increase the habitat of pathogenic bacteria or compromises the host immune response. So which both increases the susceptibility to periodontitis. On comparing the smokers and non-smokers have shown that smoking has a negative effect impact on the response to therapy. However, former smokers respond similarly to non-smokers. So then comes the diabetes. Diabetes is a clear risk factor for periodontitis. So, as we said, when there is diabetes, there is poorly controlled diabetes, which increases hyperglycemia, that is, increased production of advanced glycation end products. So, this could affect on like increased susceptibility to periodontitis or impaired healing. So, this finally leads to increased susceptibility to periodontitis. So, prevalence and severity of periodontitis is significantly higher in patients with diabetes than in those without diabetes, and that the level of diabetic control is an important variable in this relationship. Then comes pathogenic bacteria and microbial tooth deposits. So pathogenic bacteria, the accumulation of bacterial plaque at the gingival margin results in the development of gingivitis, and that the gingivitis can be reversed with the implementation of oral hygiene measures. So pathogenic bacteria, that is, not all bacteria could influence on the uh, on inflammation or gingivitis or periodontitis. Specific bacteria like Porphyromonas gingivalis and Bacteroides faucinus, mostly associated with this chronic periodontitis, and Aggregatibacter actinomycetes mostly associated with the aggressive periodontitis. Okay, so patients with severe attachment lows have minimal levels of bacterial plaque on the affected teeth, indicating that quantity of plaque is not a major importance in the disease process. Okay, then microbial tooth deposits, that could be plaque or calculus. This calculus acts as a reservoir for the plaque attachment, and then finally this could increases the risk. That is, although quantity may not indicate risk, there is evidence that composition or quality of the complex plaque biofilm is of importance. So, as we said before, these three specific bacteria have been identified as etiologic agents for periodontitis. And additional evidence that they are causal agents include their elimination, suppression, impacts the success of therapy. There is a host response to all these pathogens. Virulence factors are associated with the pathogens, and inoculation of these bacteria into animal models induces periodontal disease. Although not clearly defined as risk factors for periodontitis, anatomic factors and restorative factors that could influence the plaque accumulation may play a role in disease susceptibility for specific. As we said before, the presence of calculus, which acts as a reservoir of bacterial plaque, has been suggested as a risk factor for periodontitis. Although the presence of some calculus in healthy individuals receiving routine dental care doesn't result in significant loss of attachment, the presence of calculus in other group of patients, that those who are not receiving the oral hygiene, proper oral hygiene, along with some other factors like poorly controlled diabetes, that could affect the periodontium. It can have a negative impact on periodontal health. Then coming to the risk determinants, that is the risk factor that cannot be modified. Under that, the first one, genetic factors. There is evidence that genetic differences between individuals may explain why some Asian patients develop periodontitis and some others do not. Okay, so they have conducted various studies. Under that, one of that is twin study. So they have shown that genetic factors could influence some of the clinical parameters of periodontitis, that is gingivitis, probing depth, clinical measures of gingivitis, probing depth, attachment lows, and the proximal bone height. An alteration of this interleukin 1 genes may be a valid marker for periodontitis in defined populations. So, some of the immunological alterations can be seen, that is such as neutrophil abnormalities, monocytic hyperresponsiveness to lipopolysaccharide stimulation, and alterations in the monocyte or macrophage FcYR2 receptor for like immunoglobulin G also appear to be under genetic control. Then comes age. Age, that is that is periodontitis is not an inevitable consequence of the aging process, and the aging doesn't increase the disease susceptibility. But when we are going to the prognosis, with the prognosis, the same disease condition in both individuals, when we compare young patients with the older patients, there is a better prognosis for aged patients than young patients, because that could be more due to aggressive nature of the disease. And when we are talking about like healing process, that is more better will be in young patients compared to the aged patients. So changes related to the aging process may be due to medication intake, decrease in immune function, and altered nutritional status, So that could interact with other well-defined risk factors that could increase the susceptibility to periodontitis. So young individuals with periodontal disease may be at a risk factor for continued disease as they age. Then comes the gender. Men have poorer oral hygiene than women, as evidenced by higher levels of plaque and calculus. Therefore, gender differences in the prevalence of and severity of periodontitis appear to be related to preventive practices than any other gender factor or genetic factor. Then comes the socioeconomic status. Gingivitis and poor oral hygiene can be related to lower socioeconomic status. That is, this can most likely to be attributed to decreased dental awareness and decreased frequency of dental disease when compared with more educated individuals of higher socioeconomic status. Then comes stress. Emotional stress may interfere with the normal immune function and may result in increased levels of circulating hormones which can affect the periodontium. That is when there is compromised immune function that could increase the susceptibility to periodontitis. For example, the incidence of necrotizing ulcerative gingivitis increases during periods of this emotional and psychological stress, suggesting a link between the two. Although the epidemiological data on the relationship between stress and periodontal disease are limited, stress may be a putative risk factor for periodontitis. Then comes AIDS. There is a risk indicator that is mostly associated uh, with this periodontitis. That is immune, as you know, in AIDS, immune dysfunction associated with the HIV infection and AIDS increases susceptibility to periodontal disease. The degree of immunosuppression increases in adults with AIDS. Periodontal pocket formation and clinical attachment also increases. Then comes osteoporosis. Osteoporosis does not initiate periodontitis, but evidence indicates that when there is reduced bone mass seen in osteoporosis, that may aggravate the periodontal disease progression. However, it appears that a link may exist between osteoporosis and periodontitis, and additional studies may need to be conducted to clearly determine if osteoporosis is a true risk factor for periodontal disease. Then comes infrequent dental visits. Identifying failure to visit the dentist on a regular basis is a risk factor for periodontitis. It's a controversial. There is additional longitudinal and intervention studies are necessary to determine if the infrequency of dental visits is a real risk factor for periodontal disease. Then comes the previous history of periodontal disease. So that is a predictor. So that is history of previous periodontal disease is a good clinical predictor of risk for future disease. Patients with the most severe existing loss of attachment are at increased greater risk for the future loss of attachment also. If they are not maintaining the oral hygiene and also if they are going like decreased frequent dental visits, that could aggravate or that could initiate the progression of disease. Conversely, patients currently free of periodontitis have decreased risk for developing loss of attachment in the future. Then comes the bleeding on probing, that under risk predictor. So bleeding on probing is the best clinical indicator of gingival inflammation, although bleeding on probing alone doesn't serve as a predictor of loss of attachment. So that is absence of bleeding on probing is a good clinical parameter for evaluating the periodontal health. But when there is it's present, alone doesn't indicate is a good predictor of future attachment loss. When they are combined with the increased pocket depth may serve as an excellent predictor for future loss of attachment. Lack of bleeding on probing doesn't serve as an excellent indicator of periodontal. So coming to the clinical risk assessment for periodontal disease, so we have to assess the risk factors. We have already discussed the risk elements, each element and how it could affect the periodontium. Then coming to the clinical risk assessment before going for the treatment planning. So under demographic data, we could assess age, gender, socioeconomic status, and under medical history, diabetes, smoking, AIDS, osteoporosis, stress. Then under dental history, family history of early tooth loss, any genetic predisposition to aggressive disease, previous history of periodontal disease, frequency of dental care, Under clinical examination, plaque accumulation, calculus, bleeding on probing, extent of loss of attachment. Under tooth examination, plaque retentive areas, anatomic factors, and restorative factors. So then we are going to discuss about the clinical risk assessment tool in the era of electronic health records. So we have got clinical risk assessment tool that has been proposed by Lang and Tonati in 2003. So this allows the clinician to perform risk assessment and to plan personalized treatment quickly and effectively. So this assessment determines the patient's periodontal risk for further disease progression and subsequent tooth loss. So some of the various parameters are there which provide the basis of the periodontal risk assessment with clearly demarcated low, medium and high risk zone. So these parameters are bleeding on probing, the percentage of bleeding on probing, number of probing depths, that is number of probing depths with the greater than or equal to 5 mm. Okay, then number of lows teeth, then percentage of bone lows relative to age, systemic factors and environmental factors. So this is a functional diagram to evaluate the patient's risk for recurrence of periodontitis that has been given by Long and Tonati as we discussed before. So this is the hexagonal functional diagram. So this is like assessing bleeding on probing, that is a percentage of bleeding on probing, and then pocket depths that is greater than 5 mm. We are assessing the number of pocket depths with less than, not less than, equal to or greater than 5 mm, and also the number of tooth lows. So they have been categorized, the initial, that is a low risk, and the next shaded one is moderate risk, and greater than that higher risk. Then the number of tooth lows have been assessed. Then comes the bone loss per age, that has been assessed. And then comes the systemic factors, the presence of systemic factors, and then comes the environmental factors that has been classified as the non-smoker and former smoker. So till that it comes to the lower risk, and moderate risk under that, like smoking greater than 10 cigarettes per day, and if it is less than 20 cigarettes per day, that is the moderate risk, and if it is like more than 20 cigarettes per day, coming to the higher risk category. So the first comes, that is the bleeding on probing, percentage of bleeding on probing. So there is important objective clinical parameter. The absence of bleeding on probing determines the stability of periodontium. So when it is present, so it can be determined by light probing to the bottom of the pocket with a standardized periodontal probe. And this score comprises the number of positary sites divided by the total number of sites multiplied by 100. So that is the percentage of bleeding on probing. As you can see in the functional diagram, it has been given as this in squares, that is 4, 9, 16, 25 and 36. So this has been given, and till 9 it is low risk category, and till 25 it is moderate risk category, and greater than that higher risk category. So then comes number of pocket depths with probing depths 5 mm or greater than 5 mm. So we have to, during a clinical examination, we have to assess each site for the pocket depth. So when there is increased pocket depth, you have to assess, it should be noted. So that is the scale runs in a linear fashion. You can see that it is 2, 4, 6, 8 and 10. So individuals with like up to 4, that is considered as the lower risk category, and when there is like till 8, it is moderate risk, and if it is greater than 8, it is considered as like high risk category. So this residual pocket depth is very important to assess the future loss of attachment and also the response to periodontal therapy. Then we are going to assess the number of lows teeth. So the number of teeth present assesses the or determines the clinical function. So number of teeth lows from the dentition without third molars. So third molars will not be counted. irrespective of their replacement. So if there is like third molar, if it is replaces second molar, so after the extraction of second molar, if the third molar get drifted to the second molar position, and if that is in function, this can be counted. Okay, so the scale runs in a linear mode, that is 2, 4, 6, 8 and 10, as we said before, the pocket depth. So if it is like more than 4 teeth absent, that comes under moderate category, and individuals with more than 8 teeth loss, that may be considered as a high risk category. So that means they are not in proper function. So that is a number of lost teeth should be assessed. That is a third parameter. So then comes percentage of bone loss related to the age of the patient. So this could be assessed. The percentage of bone loss is estimated from the radiographs of posterior teeth. If it's not available, you could use bite wings also. So periapical radiograph or bite wing radiographs. The site with greater loss provides the like provides the bone loss value. So you can take the teeth with increased bone loss. So if the bone loss exceeds the age limit, that means higher risk category. So the baseline bone level is taken from 2 mm for apical to the CJ. So it has been counted from this level. So this is measured, that is 1 mm is considered as the 10 percentage. So that is bone loss is estimated at 10 percentage per mm. So this is if it is, for example, if it starts from here to this level, that means 60 percentage of bone loss for this tooth. And this has been categorized as 0.25, 0.5, 0.75 and 1 and greater than 1.25. So till 0.5 mm, that is low risk category, and if it is great the till 1 mm, that is moderate, and greater than 1 mm, that is high risk category. Then comes systemic factors. So systemic factors, under that we are categorizing whether it's present or absent. So the most substantial evidence for modification in susceptibility or progression of periodontal disease arises from the studies on diabetes patients. So we are taking into account only the diabetes mellitus, that is if it is present, that comes under high risk category, and if it is not, non or absent, systemic factors are not taken into account for the overall evaluation of risk. And genetic factors, usually if it is like genetic testing and all, it's been done, and if there is non like interleukin 1 polymorphism, this can be taken into account. So then coming to the environmental factors, and the environmental factors, smoking is the most like true risk factor of periodontitis. It has been considered in the functional diagram of risk assessment. So heavy smokers, it has been categorized as non-smoker, former smoker, occasional smoker, and smoker and high smoker. So that is the heavy smokers. It is defined by this like smoking more than one packet per day. That is more than 20 cigarettes per day. That is heavy smoker. And this occasional smoker, that those who are smoking less than 10 cigarettes per day, and moderate, that is 10 to 19. Okay, and former smoker, that is those who have stopped smoking for more than 5 years. So and having a low risk category, and non-smoker, those who have never smoked. So this is non-smoker, former smoker, and occasional smoker, that is 10 less than 10 cigarettes per day, and moderate smokers 10 to 19. If it is greater than 20 cigarettes, that is high smoker. So this has been categorized as low risk and moderate risk and high risk. So the non-smoker and former smoker has been regarded as low risk category. Occasional smoker and moderate smoker under moderate risk category, and high smoker, that is under high risk category. So we have discussed all these 6 parameters, and this functional diagram has been considered as low risk category, moderate risk category and high risk. How to differentiate that? So under low risk maintenance patients, all the parameters within the low risk category or at least one in the moderate risk category has been considered as low risk maintenance patient. And next comes moderate risk. These 2 parameters in the moderate category, but at least one in the high risk category has been considered as moderate risk maintenance patient. And high risk maintenance patient, at least two parameters in the high risk category has been considered as high risk maintenance. So we have already discussed the data collection during case history. So after that, we have to assess it. So we have discussed the parameters, the risk assessment tool, and coming to the clinical risk assessment for periodontal disease. So we have collected this is the flow chart describing the risk assessment and the following treatment plan. So that is, we have collected the risk factors under the case history, and after that we are going for risk factor determination or identification, and after that planning the treatment and coming to the treatments. So it could be positive response or negative response. So if it is positive response, that means appropriate the proper risk assessment and appropriate periodontal maintenance can be done as a follow-up. If it is negative response, then means that some of the risk assessment has to be done again. So again, we have to assess for the risk factors for any change in risk or anything we have to change, and according to that, we have to plan the treatment and then follow up. Okay. So these are some of the references. If you want to check up, you can go through it. Okay. So this is the like the site available for the risk assessment tool. You can like you do the risk assessment online also. So this is the okay. So this is some of the examples that has been done previously. So this is a number of uh, teeth and implants. You have to assess age. You have to note down the number of sites per tooth or implant and the number of bleeding on probing sides you have to give. So that is the number of sides, the number of missing teeth and alveolar bone loss. So under that, this categorizes systemic factors present or not present, the environmental factors. So this is the way how it is, and after that it will be assessed under this periodontal disease whether it's low or moderate or high risk, and also the recall interval is being given under this. So this is the site available for doing the periodontal risk assessment. So these are some of the examples that has been given for your reference and practice. Okay, so risk assessment involves identifying elements that either may predispose a patient to developing periodontal disease or may influence the progression of disease that already exists. It is useful in finding progressive periodontitis, definition of which was specified in 5th European workshop on periodontology, as the presence of at least two teeth with greater than 3 proximal attachment loss between two observation periods. It helps in evaluating prognosis reliability over the long term. Then coming to the next topic, a short note on this genetic susceptibility to periodontal disease based on the learning outcomes that are describe the inherited variations and risk of periodontitis, explain the genetic and genomic methods in evaluation, diagnosis and treatment of periodontal diseases, recognize the use of genetics and knowledge of pharmacogenomics in treating periodontal diseases. Introduction. Periodontitis requires specific bacteria for initiation and progression of attachment loss and bone loss. So there is a normal host response to this bacterial challenge. Although the normal tissue response is primarily protective, it also causes tissue destruction. Even though periodontitis requires specific bacteria for the initiation and progression of attachment loss, like it is a multifactorial disease, so host susceptibility, host response plays an important role in the progression of disease. So this healing and repair are constantly going on in the periodontal tissues. In majority of the individuals with moderate bacterial challenge, protection and repair dominate destruction. But in many very minority individuals, that is protection, this destruction could dominate the protection and so that is what we said before, that is they might have altered host responses and develop more severe destruction. So what are the reasons for this altered host responses? That could be due to this heavy bacterial challenge. So that mainly depends upon the virulence factors and the byproducts and also its bacterial species. It plays an important role in the altered host response. And the second one is the disease modifiers that reduce the protective component of the host response or amplify the destructive component. Examples of disease modifiers include the environmental factors as well as the genetic factors. So this like together could influence the modulation of disease activity. Coming to the genetic background, the first evidence that genetics plays an important role in periodontal disease emerged in the 90s. This new information introduced new concepts such as susceptibility and predisposition to periodontal disease. Periodontitis could be polygenic and multifactorial, that could be like gene environment, involvement or lifestyle interactions such as like oral hygiene, smoking, stress, and diet. Kirin and Hart in 2003 presented the classic relationship between among this phenotype, environment, and genotype as follows. So, phenotype is the involvement of the environmental risk factors, along with the genotype that includes the gene-gene interactions, and also the genotype with the environmental. That is the interaction between environment and genotype. However, the extent of genetic distribution to disease can vary greatly for different diseases. Then comes mutations. Mutation is an alteration in the nucleotide sequence in the of the genome of an organism. That is the DNA sequence. If there is any change in the DNA sequence, that is called mutation. That could be due to environmental factors also. So that is genes of major effect appear etiologic in aggressive periodontitis and some syndromic forms of periodontitis. There is also evidence of smaller contributions by genes that may modify periodontal disease expression. Specific mutations have been identified as defining the genetic basis for the various syndromic conditions. For example, cathepsin C gene papillomatosis syndrome, the CHS gene in Chidiac-Hayashi syndrome, and the beta-2 integrin chain gene in leukocyte adhesion deficiency type 1 disease. So then comes to the polymorphism. So this polymorphism, that is a DNA sequence variation that is common in the population that arises as a result of mutation. So major genetic factors in complex disease models are not single mutation. The gene variants or alleles alter susceptibility to disease. They are referred to as functional variants. Many functional variants occur with a relatively high frequency in the general population. So when a specific allele occurs in at least 1% of the population, of the general population, it is said to be a genetic polymorphism. So different types of polymorphisms are typically referred to by the type of mutation that created them. So the simplest type of polymorphism results from a single base mutation which substitutes one nucleotide for another and has recently been termed as single nucleotide polymorphism. More than 10 million single nucleotide polymorphisms have been identified in the human genome. A number of single nucleotide polymorphisms are likely to be important determinants in disease susceptibility for the more common genetically complex diseases such as chronic periodontitis. So other types of polymorphism are restriction fragment length polymorphism and symbol tandem repeats consisting of relevant allele or nucleotide repetition. So then comes the epigenetics. Epigenetics is described as the study of changes in the patterns of gene expression which do not involve changes in the DNA sequence. So that is speculated that persistent inflammation and bacterial infection may also cause DNA methylation, which inactivates the suppressors of DNA signaling and contributes to exaggerated cytokine production. So these epigenetic events act through chemical modifications of DNA and its associated proteins by blocking the binding of transcription factors. So through histone modification or DNA methylation. So the interleukin 6 gene is hypomethylated in tissues of individuals with periodontal disease compared to the control sample, suggesting an overexpression of this cytokine in inflamed tissues. So these findings are important since interleukin 6 is a key cytokine involved in bone resorption and has been detected in high levels in individuals with severe periodontitis. Then Coming to the studies designed to investigate heritability, the studies that show evidence of genetic predisposition to periodontitis can be grouped into four areas based on the statistical approaches to determine genetic components, genetic model, and study design. The first one comes the study of inherited diseases and genetic syndromes. Then comes family studies, that is able to investigate aggressive periodontitis and syndromic forms of periodontitis. And then coming the twin studies, that is able to investigate on chronic periodontitis. And then comes the population studies. So then coming to the study of inherited diseases and genetic syndromes. So various gene mapping approaches are used to identify the genes that is involved in Mendelian single traits or gene disorders. So some monogenic syndromes are associated with severe periodontal disease that we have already discussed some of the syndromes. And these conditions share the same genetic principle, that is, they are inherited as simple Mendelian traits and are usually caused by genetic alterations of a single gene locus. The significance of these conditions is that they clearly demonstrate that a gene mutation at a single locus can impart susceptibility to periodontitis. In contrast to the non-syndromic forms of periodontitis, these conditions have periodontal disease manifestation as a part of syndromic manifestation. In most cases of non-syndromic aggressive periodontitis, individuals present with clinical manifestations of periodontitis but do not appear to have any clinical disease manifestations. Then comes the family studies. This aggregation within families strongly suggests a genetic predisposition. Familial patterns also indicate exposure to common environmental factors within the families. That is more important. So the environmental factors will be same. Thus, it is important to consider the shared environment and behavioral risk factors in any family. For example, education, socioeconomic status, oral hygiene, possible transmission of bacteria, diseases such as diabetes, and environmental features such as passive smoking, sanitation, etc. Therefore, the complex interaction between the genes and the environment must also be considered in the evaluation of family risk of periodontal diseases. Then coming to the twin studies. So studying phenotypic characteristics primarily of monozygotic twins, that is a method of differentiating variations due to environmental and genetic factors. As you know, monozygotic twins are genetically identical and always they have the same sex. So always, therefore, any discordance in the disease between the twins must be due to the involvement of the environmental factors. Any discordance between dizygotic twins could arise from environmental or genetic variants. Therefore, the difference in discordance between monozygotic and dizygotic twins is the measurement of the effects of excess shared genes in monozygotic twins when the environmental influence is constant. Coming to the population studies, environmental or behavioral risk factors for a disease are often first detected in large epidemiological or population-based studies. So, a significant difference in the frequency of a specific polymorphism between a disease group and a control group is evidence that the candidate gene plays some role in determining the susceptibility to the disease. This method can help elucidate the pathogenesis of a disease process, identify host causal heterogeneity, and ultimately identify individuals most at risk for the disease. Applications of genetic knowledge to periodontal disease. At least 50% of periodontitis susceptibility is credited to heredity or genetic factors. Clinical observations as well as scientific studies have shown that the heredity of a host response pattern may be an important susceptibility factor in developing periodontal disease. So new technologies have come, for example, microarrays, DNA sequencing, or gene testing should genetic testing should contribute to the identification of specific genetic, environmental, and behavioral factors that influence the periodontitis susceptibility. So coming to the treatment strategy, host modulation as a treatment strategy. So to modulate the host response by inducing a desired immune response, that can be either blocking the progression of disease or by shutting down activating factors of bone resorption. So recent research has examined the inflammatory and resolution cascade in greater detail. They have found that endogenous and exogenous mediators can be utilized to modulate the host. So, in this regard, new drugs were a new strategy for pharmacological agents that may have beneficial effects in periodontal disease treatment. Cell and gene delivery technologies have the potential to overcome the limitation associated with existing periodontal therapy and may provide a new direction in sustainable inflammation control as well as more predictable results. Genetic test for periodontal disease. It is possible to perform genetic testing for several syndromic forms of periodontitis, but there is no evidence that mutations in these genes responsible for the conditions like non-syndromic, aggressive, or chronic periodontitis. A number of genetic polymorphism have been studied for their association with chronic periodontitis, aggressive periodontitis, for example, including that interleukin 1 genes, vitamin D receptive factor, FC, like YR2 receptors in gene, and tumor necrosis factor beta gene, and several human leukocyte antigen variants. And for the aggressive periodontitis, cathepsin C gene. However, none have proven to be strongly predictive or diagnostic or prognostic markers to identify patients within the general population who are at risk. It might be hampered by population heterogeneity and different disease criteria. Then coming to the diagnosis of periodontal disease activity, although the pathogenesis of periodontitis and its episodic nature are well understood, the application of this information in diagnostic test is still limited. Alternatively, the understanding of the genetics and the progression of periodontal disease has provided valuable information for the identification of disease markers. Currently, the detection of disease biomarkers in saliva has proved a very promising diagnostic tool to screen oral and systemic health. Therefore, the monitoring of the qualitative changes in the composition of these biomarkers may have a diagnostic value by identifying patients with enhanced disease susceptibility and associated systemic conditions, identifying sites with active disease, predicting sites that will have active disease in the future, or serving as surrogate endpoints for monitoring the effectiveness of. So, to conclude, currently the presence of interleukin 1 gene variations appear to identify individuals who are at increased risk for severe disease and for less predictable response to therapy. So, better genetic knowledge, proper analysis, diagnosis, and treatment planning lead to the success of periodontal therapy. Thank you.